Use in Pregnancy, our Navigator training focus series. This is our monthly training with CEUs. So we're happy to have you guys here. As you know, we are a part of Public Health Institute, and we do share our materials. You will receive a follow-up email with the resources and the slide deck that we presented today. And for your best experience, the most important thing on this slide is to remember, if you have a question, address it to everyone. Make sure it's the little blue box instead of just one person or the panelist, because everybody wants to know what's your question when the presenter is asking. So, and also if you want to raise your hand, if you have a question, let us know, and we will try to get that to our speaker. Of course, closed captions are available. So, you know how I start. You guys can probably do this for me by this time. We are California Bridge. Our goal has been very simple: 24/7 access to high quality treatment of substance use disorders in all California hospitals by 2025. I think we've done a great job trying to reach this goal. We're more than 75%. So I'm going to say, you know what, we still have work to do, but we're so proud of all of our sites and our representatives today here. You are the ones that are making this happen. I real quickly want to go through our CA Bridge model and our system of care. You know, it's our three-prong approach. It doesn't change. Simple, low barrier treatment. That's your docs giving buprenorphine or whatever MAT treatment in the emergency room. Low barrier, of course. And then the last two pillars, which are connection to care. That's you giving the warm handoff and linkage to community referrals, inpatient treatment, wherever that patient needs to go and be navigated. And then our last pillar is a culture of harm reduction. And we know this probably takes a lot of your time, just reducing stigma and making sure people are safe. So again, that's our CA Bridge model. We do have a few announcements. If you don't know, we're happy to announce that CA Bridge is now offering community health worker certification. So what does that mean for you? You can apply, and you will get an authentic CA Bridge via our partner Department of Healthcare Services certification, and this will help your organization move on to their plans if they're going to do the CHW Medi-Cal billing. So more information to come. We will have a webinar, but this is a first step to making this happen. So if you need more information, reach out to mentors@cabridge.org. We're going to drop this certification guide in the link. It should answer all your questions. Everything is on there. And again, if you have a question, please feel free to reach out to us. Our next month, we always talk about next month because we don't want to leave you empty-handed. We have our July 18th is trauma-informed care, another requested just like today's topic. And August 22nd is overdose confidentiality and ethics. Just a reminder, International Overdose Awareness Day is coming in August. Do you have plans? So if not, that's okay, guys, plenty of time to plan. We also have our Navigator update. That's our 30-minute chat session. If you want to come in and just drop in, it's a great way to get questions answered and to learn. Just do a little topic very quickly. Motivational interviewing is in July, and August is promoting opioid awareness and prevention. So if you don't have a plan, come visit Latoya August 14th. She'll help you, promise. All right. We also want to highlight our Spotlight Navigators for June. If you don't know what this is, we recently started this year highlighting some of our exceptional navigators. We know you're all exceptional. And, you know, definitely we're going to continue this program monthly to just acknowledge and appreciate you guys and give you a spotlight. So if you haven't got it yet, no worries. We're sure you are doing amazing things. Just give it time. But these are our June Navigator spotlights and their hospitals they work at. Okay, these are our objectives today. We kept it simple. You're just going to understand the importance of substance use in the treatment in pregnancy and harm reduction strategies for pregnant patients. That's something, again, that we always want to make sure that we're doing the right thing, and some of those myths and rumors. We want to dispel that here today. So before we get started, I want to do a poll. Aiden, if you can put that up. We're going to start by polling because we don't know how many of you guys already meet with pregnant patients. That's our first question. And then our second question is, do you encounter patients or who are parenting infants? Do you even talk about that if they have children in their home, if they're, using substances? Do you have that encounter? So we want to know, these two questions, we're going to give you a minute to answer these. So again, we're just trying to fill our audience out there before I present our next speaker. So she kind of can delve into, what is your experience? We know some of you have kind of infiltrated in the whole hospital and some of you are still in the ED. There is no right or wrong question answer here. We just want to know because again, this is not something that we have been training on. So, it really helps guide us with our next trainings. Okay, I think we're going to close that poll. And while he's closing that, let's see our answers. 75% say yes, you're already meeting with pregnant patients. I like that. So 25%, that's okay, because there's a lot to learn before we start that. So you're going to get some foundation today. So that's awesome. And nobody's not sure. So I'm glad it's either a yes or a no. Okay, so do you encounter patients who are parenting? 67 said yes, 22% said no, and then some are not sure. And again, we don't know if that's something that you're asking questions, and hopefully today we can give you those tips. So I'm glad that there's room for you guys to learn with us today. And thank you for answering. It really helps us kind of guide us with our conversations and our trainings. So I'm going to go on to our next slide. And it is my honor to announce and to present Dr. Rebecca Trotzky-Sirr. If you don't know her, she's going to tell you a little bit about herself. But you know what? One thing I want to just appreciate Dr. Trotzky-Sirr is her commitment and advocacy, not only for people who use drugs, but for our navigators. She will go out of her way to help you and a patient. I mean, so many times we have asked her, and Elizabeth's here too and can vouch, she will go above and beyond. I know she's out there in LA. If you don't know her by name, she works behind the scenes in LA County, and she's very humble. And it's an honor to have you here with us today talking about this subject, Dr. Trotzky-Sirr.
Thank you, everybody. I'm so excited to be here always, and I'm always excited to hear your questions, hear how everybody is learning. And I'm going to share my slides. A little bit about me. I come to addiction medicine world from actually reproductive justice world, where I had my first kid when most people consider me too young, and now he's 25 and like off doing Europe and all these adventures. And during COVID, I decided to have 2 more kids. So that's me. I have now a 1-year-old and a 4-year-old and a lot of chaos in my house. So I know a lot about, the hustle of trying to be a young single mom and go to school and work and figure out life. And that's really, I think, what grounds me in a lot of my clinical experience is the community that we built around supporting each other as young moms and going to school and kind of meeting our life goals as best as we can. And I've had the privilege of working with California Bridge since really the beginning. And Lady Elizabeth Keating is my boss. She helped work on these slides with me. And I just want to share how excited I am that we're really bringing that intersectional work together. I think the base you guys have grounding and supporting our patients is so strong. It's only going to be blossoming further as we do more and more care. So I also have the privilege of reviewing maternal mortalities. So what is that? In the state of California, Southern California region, looks at every single death of a mom related to pregnancy. So during pregnancy and the year after. And we look back and we say, what could we have done differently? What could we have done better? How could we prevent this situation. And so often there's this commingling, as you guys know and live, of poverty, lack of access to care, uncertain follow-up, like not knowing where to go, feeling stigmatized about going there. And often there's only like one or two medical charts from our review, and it's an emergency room, right? So we'll see something like a lady comes in at 10 weeks and learns she's pregnant in the emergency room. And then the next chart is when she's really, really sick sometime later. So I really want to value that while the ER isn't where we all want people to receive quality prenatal care, we want them to receive that in, OB settings. It often is the place where people come for emergencies related to their health, and they learn that they're pregnant, or maybe they knew they're pregnant and they're having a pregnancy related emergency, or even afterwards, right? They delivered and they come to a different ER with an overdose or shortness of breath or something unrelated. So the care we all get to provide together sometimes is that welcoming touch that can change somebody's life and change the trajectory of their family and their babies. A lot of us may know this language, especially if we've given birth or supported somebody giving birth in the past, but just in case there's this alphabet soup in the hospitals, if you have been sitting in the ER, you might not have heard of all of these resources in our healthcare system. For patients who have complicated pregnancies, and they're in a planned setting, they're often going to MFM doctors, which stands for maternal fetal medicine. And those are the people often supporting our patients who we know are using drugs and need extra help and support. But I've given a lot of information here about, words you might not be super familiar with, like you're like, what is the NICU? Where am I supposed to go? What am I supposed to do? And this is mostly just to orient people who are not used to hanging out with laboring people. And I also want to understand, kind of asterisk, the welcoming language we get to use in birthing. And I also am transitioning to this language, and it can be different for some people and in some settings, but we really want to anchor words that can welcome everybody in. And, once your patient is identifying to you what words they prefer, you can use those words. But both in the birthing context and pregnancy context, we're aiming to use a less gendered approach. So instead of a maternity ward, it might be a birthing center, right? So we are acknowledging that some people may not identify as female or may not identify as, male, female partnered having a baby. They might have lots of different options. And then we're also looking at less stigmatizing language around substance use disorder. And this is probably pretty familiar to many of you, using that person first language. So one of the things we've seen in the past is kind of these, this baby is an addict or born to an addict, or a lot of stigmatizing language still filters into our ears. And we really want to be this like center of support for our patients, no matter what they go through. And this stigmatizing language also falls in the way of reproductive healthcare services. So, we just want to make sure that we can support, whether this is uncertainty around drugs, uncertainty around pregnancy, uncertainty around parenting, we can support this person with as neutral words as possible, as like specific words as possible, and as science-based words. So for example, I'm just picking one out. This patient is displaying behaviors that might increase risk, right? So instead of saying, they're having sex with 17 people, right? You can just say their sexual behaviors may increase risk of STDs. So it's really has less shame, less stigma, and really alerts the other members of the medical team that we're not going to tolerate that shame around our patients anymore. And we're building that new world we want to work in. The essential care for pregnancy, parenting patients remains the same, and the essential care includes the reproductive services that we all need. So creating a supportive environment, making sure we know who's in the room, making sure we ask people to step out of the room in a kind and empathetic way. Like, it's just the policy here where I always need to talk to my patient for a little bit of time without anybody in the room. It's nothing against you, sir, nothing against you, mom, nothing against, to make sure that we have that opportunity to really hear what's going on as best as possible. Be not judgmental. I'm here to support you, whatever your decision may be. And that's, right, for so many decisions our patients are feeling, they might feel pressured one way or another. And providing that active listening, like, I'm listening, I want to know how you're feeling, it's okay to tell me. And I think you guys really display this new way of being with our patients more than anybody else in the healthcare sector. So I'm preaching to the choir here. If somebody's displaying a lot of emotions or just kind of has that look of shock on their face for whatever reason, like maybe they just learned they're pregnant, or maybe they just learned there's something wrong with their pregnancy, it's normal to feel a range of emotions. Just acknowledging that big elephant in the room. It's normal to feel uncertain. If people have to make care decisions, you can acknowledge it's a big decision, and I'm here for you no matter what. Your feelings are valid. And I think these are phrases that you guys are very accustomed to verbalizing with your patients and your community members. Informed consent. So this is both around treatment, around urine toxicologies, around workup. Like our patients, we want to have them be our kings and queens. They're the people directing kind of what's going on, and we're here to advise and offer information and offer opportunities, but their job is to pick what they want to do. And our job is to support them and provide, hopefully a downhill right course into an easy treatment. But sometimes people choose things that from the outside look like a different choice than we would have made, and that's okay. So whether this is about reproductive healthcare services, the decision to parent, the decision not to parent, just acknowledging that that person has the right to choose what's best for them. We might not know what that is. There's no right or wrong choice, right? We have a huge range of humanity and very complex choices in front of us. And I can often say that, I chose to parent at a time when everybody in my life was like, that's the craziest thing we've ever heard of. Like, you're never going to make it, a lot of naysaying, you're never going to go to college, you're never going to go be a doctor, you're never going to do all these things. And, it was a hard choice for me. It was a hard choice to continue. And I'm not saying it was a right or wrong choice. But there was a lot of judgment on all these different sides, right? So just to help that person make the choice that they want to make around all these things. And then our job is always to connect to resources downstream. So we might see them in a moment of chaos and crisis, and like we are that bridge into transformational, like calm and centeredness. So we're here to connect you with the resources and support services to help you downstream. And that's like the golden piece of advice I can offer you. You guys are such quality people in terms of taking that bridge moment from crisis to centeredness. Some people might not know already that pregnancy is a very high risk time in general for women. This is one of the highest risk times for our mortality in terms of younger women, right? Like not our 70s and 80s, but reproductive age women. When we are in a moment of reproduction, that is a high risk time for death. But in particular, overdose deaths are now the highest rate of death for pregnancy. So we learn a lot about bleeding in pregnancy or preeclampsia and other diseases, infections, but overdose deaths remain the highest rate cause of people dying, whether they're pregnant or not pregnant right now. So addiction care and the support that we can do is a healthcare reproductive service, making sure that our moms and our birthing parents stay alive and healthy during that pregnancy and afterwards is support for that family, whether they choose to parent that pregnancy, whether they choose to terminate that pregnancy, whatever they want to do. And we also acknowledge, know, and like feel that experience that there's even more stigma around these choices, whether it's addiction choices or reproductive choices. If you're young, poor, single, queer, on the kind of the marginalized side of society, patients of color, and patients who use drugs. So there's a lot of intersectionality here that you all are living in the first line of. And a lot of people who learn they're pregnant in the ER have a fear, and that fear is real and based on reality, of family separation and criminalization if they are using drugs actively, if they recently stopped using drugs, or if there's this like cloud over them that they may use drugs. And that has a lingering problem in healthcare where, how many times have we heard these stories in our community, in our families, and in the healthcare setting of families being separated because people are using drugs? And we know as a fact that that family separation is as traumatic as anything else. It's not necessarily healthier for a child or a baby to be separated from their family, especially when we can provide support and treatment for that family. That's not to say that never should we separate a family, but by and large, we've been over separating families and not creating health in our communities. We know that there's very low rates of access to addiction care, period, in general, and even lower rates during reproductive time. So when somebody's pregnant, when right after their pregnancy, and the intersection of finding, a resource that's really good for them with comprehensive reproductive healthcare services and addiction care, woof, that's like sometimes this, very, very hard to find. And our job is to help highlight those resources in our community as navigators that are particularly good, or which names can you help that person navigate to on the outpatient setting that's going to treat them well and validate what they're feeling. So I see a lot of pregnant patients in my clinical experience as a director of addiction care at LA General, which is the biggest safety net hospital in Los Angeles. So here's, an example of a patient that we saw, 23-year-old who was in our fast track area in our emergency room. She's coming in because she had a panic attack. She's having struggling breathing. She had a history of asthma, and she also wants to use less meth. These are all interrelated. So she's just she also smokes fentanyl. So we've engaged the addiction medicine team, and you're in the room talking to this patient, doing your normal, here's some Narcan, what do you know about fentanyl test strips, yada, yada. And the nurse comes into that room and says, you're pregnant, right? To the patient. That urine test we got for the x-ray that we're going to get for your chest, it came back positive. And you're in the room when Sarah realizes she's pregnant, didn't know that, and she starts to cry. So this is an experience that's very similar to many experiences that we've had. Maybe those are tears of joy, maybe those are tears of surprise, maybe those are tears of sadness, who knows at that moment, but it's a very challenging moment. So I just want to pause and take a breath. If you've been in that position, that's a scary time. If you're supporting somebody in that position, it's a challenging time as well. And so, how do we talk to our patients and how do we talk to our healthcare team? And those can be slightly different languages, but it's important to really anchor again that patient, that woman, that person who is pregnant is the boss of all these choices. And we have to give that person as much support, agency, and love as possible so that they can make the choices they want to make without pressure from friends, family, outsiders, including us. So deciding when to have kids is your choice and you're right. That's one of the phrases that I use often in that setting. Whoa, surprise pregnancy. I'm not sure if you want to, if you're happy or you're sad. Just want to let you know, deciding when to have kids, it's your choice and you're right. And everything from this point is to help you make that decision in a way that best support you and your friends and family. And that's an important thing to feel comfortable and confident saying, because probably nobody else in that room is saying that to that patient. So in terms of communicating with other people in the healthcare team, how do you phrase some of this is important. So we talk about between people who are really committed to this work, we're managing reproductive healthcare options. We're helping our patient make plans to space their pregnancies if they're interested in that, or choosing when to have children. We're managing health outcomes of unexpected contraception outcomes, right? So maybe she was using condoms, a condom broke. Maybe she thought her IUD was still active, but it was placed, 15 years ago, who knows? But it's an unexpected outcome. It's not necessarily a failure of her or a failure of, anybody. It's just unexpected. We want to offer her, let's say the pregnancy test came back negative and she's like, oh, thank God. What is some more effective contraceptive options we can talk to you about to help you, whether they're hormonal contraceptive options or non-hormonal contraception options. So you can see this language is kind of, plain, neutral, scientific, health oriented, just in the same way that we've transformed language around addiction. This is the kind of language that we would want to use to support a person through pregnancy, birth, and beyond. One of the important things I want to offer is that just like Narcan is available for emergencies, where nobody's like, oh yeah, let's rely on Narcan to treat somebody's substance use disorder long-term, but we want to make sure everybody has this available. In the same kind of way, we want to make sure people have emergency contraception available if they have a risk of pregnancy. So people might not identify as heterosexual or having sex with men. If they're female, they might not identify as sexual active at all. Maybe they're asexual or never had sex before in their life. Maybe they don't even identify as female, right? A lot of trans men still can get pregnant, even, with all the testosterone and changes. So if somebody has a uterus and they're able to get pregnant in that age, it's important, I believe, to be able to talk about emergency contraception. Also, I give all these kind of unusual situations because sexual assault is really common. It's common, when you're living in the streets, experiencing homelessness, when you're using methamphetamines, all different kinds of reasons. Even when you're like, I don't have a partner who can get me pregnant, it's still possible that you could be a survivor of sexual assault that could put you at risk of pregnancy. So I really almost provide 100% of my people at risk of pregnancy, even if they don't identify themselves at risk of pregnancy, with contraception, emergency contraception. So this is something that you can take as soon as possible after an unprotected or underprotected sex act, whether it's transactional like sex for drugs, or coercion, or assault. This is something that really can help somebody reclaim their life. Plan B is an emergency contraception option, and it's available over the counter for like a gazillion dollars, like 50. Prescription emergency contraception is called Ella. And so any physician who can prescribe and write an order for naloxone or Narcan can also prescribe Plan B or Ella. And this is important to kind of remind our providers. It's important for us to help our patients advocate for that. I'm a big fan of like, everybody should have it in their pocket, just like we have naloxone, even if I'm not at risk of an opioid overdose event. It is important for me to be able to help a friend, to help somebody I see on the street. And so this is an important resource as well. To note, emergency contraception does not harm an existing pregnancy. So if this person was 6 weeks pregnant, didn't know it, 1 day pregnant and didn't know it, if they took either of these medications, it would not change the outcome of that pregnancy, doesn't affect the developing fetus, doesn't cause miscarriage. So it's an important to, just in case, have in the back pocket. I'm going to pause here because I know I just said a bunch of information. Is there anything in the chat or anybody want to ask a question?
You know what, Rebecca, I don't have any questions yet, but I loved, some of the key tips, you guys, if you need to hear more, some of the words, I love how you say it, being pregnant wasn't a failure. It's nobody's failure. It's unexpected. So I just love the terminology. Anything else from our audience? Any questions? You have Dr. Trotzky-Sirr here, so definitely, chat in. But the words are so important, like you're stating. That's just one thing, is learning the terminology, and it's like you said, we're all learning together. Trying not to offend people. So I just wanted to bring out those key points. Anybody else? We're here, and just type it in the chat. I'm going to let you.
Thank you. Substance use disorder and treatment for opioid use disorder during pregnancy, if somebody's planning for a pregnant or if they just were pregnant, it's still the same as all the great things we've already learned. Still medication first. We're still offering buprenorphine, same dosing, all those things. What's interesting about pregnancy is it feels like, both people who are pregnant or your friends and family and even doctors have a lot of like, oh my gosh, what do I do? I'm pregnant. I can't take, I can't have a sip of tea. Something might happen. Like a lot of anxiety and a lot of myths. So I want to just say that's normal to have a lot of anxiety and myths and uncertainty. And we know as scientists that buprenorphine, still exactly what we do for non-pregnant people, is exactly what we want to continue for pregnancy. So while our doctors might be like, I'm not sure, if I should continue buprenorphine, our message back to them is like, yes, please do. This is what's going to keep your patient alive. And keeping your patient alive means this, pregnancy will be healthier.
Okay, Dr.
Yes.
Trotzky, I have a few questions now related to the Plan B. They want to know how it does not harm an existing pregnancy.
Yes. They want to know how, or just to confirm that it does not.
How? Because they're saying they're taking it
to prevent a pregnancy. So
right.
if you guys can remember, right, the egg and the sperm meet, then that's conception, and then the egg and the sperm have to go into the uterus and do a whole bunch of things to result in a successful pregnancy. What both of these medications, Plan B and the other one called Ella, do is prevent the ovulation from happening in the female partner and the woman partner, or the person with ovaries. so that that egg and the sperm can't meet. But once those things are already met or developing in the uterus, those things don't change. So it's stopping, you know, like if you think of all the processes of the chain, like 1, 2, 3, 4, 5, 6, 7, 8, you're stopping going from, you know, 0 to 1, not stopping something downstream. So if you're like, if I'm like, you know, 9 months pregnant and I take this, it's not going to do anything. Does that make
Perfect.
sense? Yeah.
Oh, totally. Yeah, that totally makes sense. Now, the other questions, I have two more here. If a client is on MAT, MOUD, will EC have any effects on those medications?
Not at all, totally different system. So continue your buprenorphine every day. That's the same message. And emergency contraception won't change the effectiveness of those medications either way.
Okay, and then we have a question, and I don't know if what are current SUD trends in patients who are pregnant? Is there any trends?
Yeah, I would say it's the same as the general population, right? So increasing fentanyl, increasing stimulants, increasing both fentanyl and stimulants, and increasing rates of opioid use disorder and overdose deaths. Um, that's my experience. That's what's been kind of floating around statistically. I think it's also a really hard population to pin down because it's, again, so stigmatized and criminalized, and not a lot of pregnant people are going to venture forth and be like, yeah, I use drugs, especially if you're not already labeled as such, right? They're not going to offer that information very easily. So I'm sure we have a lot to learn collectively as a community.
Great, thank you. I think we're all caught up.
Thank you. So MOUD, medications for opioid use disorder for parents. Postpartum period right after delivery is a high risk time for depression. It's a high risk time for relapse on any substance. If somebody's using alcohol, it's high risk time for that to happen. It's a high risk time for overdose death, probably due to the stress of delivery, the stress of dealing with those hormonal changes and everything that goes through the body, but also probably a time when you went from an intense, like, you know, a lot of visits with medical care, a lot of visits from friends and family, to all of a sudden that kind of is pulled back right after birth and delivery. So that might be one of the reasons too, that it's one of the highest risk times. So I always tell my pregnant patients, like, continue your medications even through pregnancy, delivery, and beyond. I want to make sure that, you know, the last thing on your mind is like, oh, a relapse, or a trigger. Like, I want you to be able to focus on yourself and your family rather than all these other things. So please continue this medication. There is this kind of vibe that happens, I think, and you know, I feel guilty of it too, which is like, when you're pregnant, you want to make all these healthy life choices for your baby, for your pregnancy, instead of being like, hey, I'm a valued person as well, and I want to make those choices for me. So it's often a time when people might be able to like go a little bit above and beyond, right? Quit smoking or quit drinking, and really just like cold turkey and all those things. People don't have to cold turkey anything, right? We want to be there so that they're not experiencing withdrawal, that they have less cravings, they're not like biting their nails. Because when delivery happens, we want them to feel like, hey, I'm as valuable as this newborn little baby, and we want to make sure that we're making healthy choices, not just for them, but for me. And I think that's part of the kind of cultural narrative that maybe is contributing to why postpartum is such a high risk for all these things, right? That support for mom, that self-love isn't necessarily as strong in our community. There's a lot of myths for, you know, hey, medication isn't good during pregnancy. That's just not true for buprenorphine during pregnancy. It's also an opportunity to bring in all those loved ones around mom and family. So boyfriend, partner, parents, other kids, other people in their life, roommates that have substance use disorder. It would be great for them to come and engage in care as well. So I always keep an open door. Like, I'm seeing the pregnant patient, but I'm like, hey, if you know anybody else, you know, and then I'll name like mom, dad, you know, blah, blah, blah. I would love to see them too. Here's my number, here's my card, have them come next time. We can have, you know, an over the phone appointment anytime so that they can get started on buprenorphine as well, or, you know, just talk about what's going on. And also just, you know, sometimes partners aren't that supportive at all too. So really just clarify with that pregnant patient, like, do you want me to talk to your partner? Do they know what's going on? Is this, you know, something we need to be really silent about? Are you guys open about these issues? And really understanding, so we're not putting that person at risk at all. and then really having that open, wide door, right? I would love to see you now, today, in 3 years, whatever. I want to see how your baby's doing. I want to see how you're doing, and kind of having this door as wide open as possible. I do always use patient-led dosing. Like, I'm not trying to be like, you must take 16, you must take 24, you must take it at 10 p.m. Like, what works for you? I know that I want to get them towards a higher dose of like 24 to help patients stay abstinent from opioids. And there's this mental myth around, again, pregnancy. We want to use the less as possible, right? And it's just so often that I see somebody kind of tapering down because they're in that myth zone, or maybe their provider's in that myth zone. So they're at a steady state dose, they don't have cravings, but then they're like, okay, I just took half of it because, I'm pregnant, I don't want blah, blah, blah to happen. I'm like, this is safe for your pregnancy, it's safe for your baby, it's safe for you. Please don't underdose yourself. Don't like make yourself be nail biting and having cravings, because a lot of stress going on. We want to do whatever we can to get meds in mouth as supporters of this patient. So pharmacy barriers, transportation barriers, childcare barriers, like how can we help you? And then the flip side of that is not getting so focused on substance use disorder that we forget about all the other family support that we can do, like emergencies for her, emergency contraception. Does she want to have more kids in the future? Or we want to make sure that she has the pregnancy options available to her, and then the long-term contraception, so that she can plan like, okay, I'm going to have this child now, but I'm going to, try to avoid future pregnancies so that I can go to college, so that I can do these other things. And we're here to support her kind of thinking through that long-term process. There's only a few graphs in this presentation. You guys know that buprenorphine is really the safest thing for people in general, keeps people alive. Also, after pregnancy, I want to say methadone is always an option for pregnant patients. When babies are born exposed to methadone, they tend to have a little bit more withdrawal symptoms. Those aren't necessarily life-threatening withdrawal. We can treat them very well in healthcare settings. But just to be mindful that we can keep babies going, how do we say it? We get to have babies rooming in with mom, not having to go to a higher level of care like a NICU, get to go home with mom much more frequently on buprenorphine than we do on methadone, because they're not feeling a little bit, bad with that withdrawal when mom's on buprenorphine. The quick start guidelines are the exact same thing for pregnant or non-pregnant patients, just to help your doctors. We have guidelines on California Bridge, and really they don't need any additional barriers. They don't need to come in for labs. They don't need to come in for an ultrasound. Like, of course, we want all those labs done because we want a healthy pregnancy if they're choosing to continue. But, in terms of starting buprenorphine, we don't even need to have a urine toxicology that shows they're pregnant or not pregnant or how long they are. Buprenorphine is the important thing to get in their bodies. This is kind of going back to the conversation around pregnancy options. In general, like going back to that case study when that person's crying, just learned that she's pregnant. I'm always like happy tears, sad tears, that kind of thing. But, let's say she's just like shocked, I can't be pregnant, I don't know who the dad is, all these kinds of things. There are a few options available to you: ending your pregnancy, or giving birth and parenting, or giving birth and adoption. Let's talk about those strategies. Like, make sure that she's aware that we are here for her no matter what she chooses. The healthcare environment in California is very strongly supportive of people choosing their own options, which is so important, because that is not how the world is in the rest of this country. We want to encourage her to follow up. Like, I know this is a lot to think about. I know you're going through withdrawal right now too. Here's a way for you to feel safe and comfortable. And, here's a phone call for you. Like, do you know, this is now for you as substance use navigators, like, where would you send that person if she was like, yeah, I think I want to engage in prenatal care? Do you know like who in your community is going to help that person without that stigma? If she's like, man, I just can't imagine continuing this pregnancy, where can I go? Do you know where to send her? And then to message that regardless of those choices, buprenorphine is important for you and for, potential baby if she's choosing to give birth, and how can we help her during that busy time. So we, as a community of healthcare supporters, get to ensure that we have cool prenatal care services and other reproductive healthcare services available at our fingertips. There are some good websites available if people are choosing to end their pregnancies. This is one, abortion.ca.gov. It has a list of providers, a list of financial resources, and a lot of information to dispel myths in a lot of different languages. Also, there's a lot of information online around birth control to know that like literally almost all of our patients are, eligible for free birth control, including a year supply all at once, and other permanent options. And pharmacies are able to prescribe birth control themselves if they don't have a doctor. Like a patient can go to a pharmacist, and there's an online link to find those pharmacies that make that service available to our patients. In California, there's the family pact. Like, so if you don't have insurance, if you can't use your insurance, there's a system of care so that it is low cost or no cost to our families as well. So our job is to like help those people find those resources and just know a little bit about them ourselves should we need to refer somebody to them. Any questions at this point?
And we do have one. And any ideas for navigators to find a clinical champion in helping pregnant patients?
Yeah, so I generally start with my midwives. Those are people trained to kind of more be a person-centered anchor in the labor and delivery community. And you can ask them and be like, my job here is to support people, including pregnant people who have substance use disorder. Who do you think would be the person to talk to? They might be them, or it might be somebody else, and they should be able to point you in the right direction. But you're 100% right that it's sometimes really hard to find prenatal care, OBGYN care, labor and delivering care for people who are using drugs. And our job is to like try to smooth that down, right? Try to dispel the myths. And there's a lot of myths, right? And these are myths that are so pervasive in our community that sometimes we don't even recognize them as myths because we think they're true. So for example, this whole concept of a baby who is exposed to drugs in the womb is addicted at birth and going to have all these future problems. That's actually quite a myth. So newborns are not addicted. Addiction involves like those compulsive behaviors. They can experience some withdrawal. All of the withdrawal can be effectively managed with medical care. So these babies can be supported and they will not necessarily have long-term consequences from the drugs that they were exposed to in the womb. That said, alcohol has a specific syndrome associated, right? Fetal alcohol syndrome. The other drugs can cause early delivery and small babies during pregnancy, and that in of themselves can cause some problems. But in terms of causing long-term brain changes just from the drugs alone, that has not been shown to be true. So it's important to provide compassionate and non-judgmental care for pregnant people with substance use disorders so they don't shame themselves, they don't blame themselves. It's definitely exaggerated and or false that there's going to be severe permanent damage due to drugs in pregnancy exposure. So most of all of those things that have been shown are confounded because somebody's poor, because they lack prenatal care, because of all these other, like STDs or other things that they might have that didn't get treated. When we equalize for that, there isn't long-term severe permanent damage, for age-adjusted pregnancies and all these kinds of things. Only alcohol has that specific fetal alcohol spectrum disorder. So there's a lot of myths, right? Like that kind of is like mind-blowing, and people will be like, no, that's not true, right? Like if you are exposed to crack, then you're going to have all these problems as a child, as an adult. But when we can provide that child with resources, love, care, support that family, they're going to be able to overcome that. So most babies and children and people who are exposed to drugs during pregnancy do not have severe lasting impairments. The impairments that may exist because they were born premature can be completely overcome with sufficient support, or I shouldn't say completely, but mostly overcome with that.
We have a question.
Yeah.
Is there a protocol for pregnant people who for alcohol disorder? And how
So,
can navigators advocate
yeah.
to support these patients?
So just like all the other people with alcohol use disorder, it's a combination of medications, usually naltrexone, sometimes gabapentin, and kind of outpatient treatment or social support. So those kinds of programs that help somebody be in a space where their brain is kind of resetting. So those are also true in pregnancy. A lot of the medication for addiction has not been, FDA approved for during pregnancy. However, we have not seen these medications cause harm in pregnancy. And if there is a risk for, just because there's not a lot of information, the risk for continued like alcohol use is so much worse, that you can make a shared decision with that pregnant patient. Like, we don't have any information about this drug's causing problems to you or the pregnancy. However, not a lot of information out there. And we do know that there's harm from continued use of alcohol. We think this will help you use less alcohol. What do you think, right? Helping her make those decisions and informing her of the risks, even the risk of like, we don't know a lot. But I want to support you. Like, what do you think you need to get that support? Do you want to try medication? I can provide that to you, and let's talk about it, right? That's how I present that information. In terms of breastfeeding, oh my goodness, you guys, I'm sure you've heard a lot of myths as well. I keep hearing them in my hospital that, such and such mom can't breastfeed her baby because she, used meth 3 months ago. Something random like that. That is not true. These drugs metabolize out of a person, stimulants like meth or cocaine, within days. So definitely within hours to days, somebody can breastfeed. They can definitely pump and dump if they're worried about their breast milk. There's always a concern, like if I'm holding my newborn baby and smoking meth at the same time, that baby's going to get that secondhand smoke. We don't want that. But in terms of mom, like 3 days ago, she smoked meth. Now her baby's born. Can she breastfeed? The answer is yes. And again, maybe we don't have 100% information, but you can say, hey, this is metabolized out of the urine. It's metabolized out of the breast milk. We can't 100% guarantee that every single tiny drop of meth is metabolized, but it's very low amounts, and we can monitor your baby here, go ahead and breastfeed, make sure things are going well. Like, that is a fine, let the mom make that choice. So I want to really advocate, not that you have to breastfeed. Like, a fed baby and a happy mom is the most important thing. So I'm not saying everybody must breastfeed, but if she wants to breastfeed, please, by all means, like, let's support these choices for our patients. And for trans people giving birth, a lot of the times the language is chest feeding, which might be new to some of our patients. But if you hear that, that's just a less gendered way to discuss milk, human milk. So human milk, when using drugs, I always say, like, please, like, if they want to have that like bonding experience, please do it, right? It's okay. Definitely after stopping using unregulated substances for hours to days, anybody can do it. Definitely when mom or person is on buprenorphine or methadone or medication treatment, it's okay to breastfeed. And if there's any uncertainty, you can pump the milk and dump the milk and continue to breastfeed going forward. And, there's lots of reasons to continue to breastfeed. So this is a big topic in my hospital right now. The other big topic is mandatory reporting. We have maybe 10 minutes between all of us now, and I feel like I talked a lot. So I want to make sure I leave at least 5 minutes for questions. I want to reassure you guys, this concept of somebody uses drugs, now we must report them to Child Protective Services, that is not true. Mandatory reporting is for child abuse and neglect. People use drugs all the time and are not neglectful and not abusing their child. So it happens to be the case that we have a lot of feelings around pregnant people who are using drugs. And it is important to evaluate that person's ability to care for that child. But drug use alone or a urine toxicology result alone does not mean that person's not a bad parent. And often with support, care, and love, that family can do really well. So the goal is to further assess and see if there's any functional parenting impairments before like ringing all the bells and reporting. So that's a big game changer. And I think we all in this conversation are maybe some of the best people to help and support those people parenting and making good choices for themselves. There is a new federal law that's supporting this concept of we want a plan of safe care for that family rather than reporting everybody. So you might hear that phrase, plan of safe care or family care plan. That's going to be helping people connect to resources downstream. I want to say that a lot of times doctors, and myself included, can just do wrong things and say wrong things, and you guys might know better. And that happens not uncommonly. So I always am like, why might the doctor be wrong? Is it because they just didn't know? So things that I hear all the time is like, we have to file a DCFS report because we're mandatory reporters. That's just not true. You guys just learned that. They have to evaluate and make sure that patient has sufficient care and support so that she can parent well. And if they have concerns still after all of that, then you can consider mandatory reporting. You can offer that with the patient. You shouldn't let the patient know about that. But sometimes doctors are wrong because they have old information. They don't understand the systems of support, especially for poor people. They might not know the full story. They might just know like one piece of a test that happened 6 months ago. They might not know since then this patient's been doing A, B, C, and D. They don't have a lot of experience with this topic. You guys are the experts a lot of times in your healthcare system. And when in doubt, you can always be like, let's talk to social work. Sometimes social workers are also wrong. You can always kind of call us for support about how to frame an issue, or maybe just to be like, hey, can you talk to my docs about this concept, that concept, because we have a lot of confusion or the law changed and we want to, get people up to date. So phrases that work for me is like, yeah, many people think blah, blah, blah myth, but I was surprised to learn that blah, blah, blah myth isn't true. So I say things like that, or I used to believe such and such stigma, but then I saw a new article that said blah, blah, blah. You can say things like, oh man, yeah, it can be really frustrating to hold two different ideas at the same time. Like we wish all moms never use drugs and we want to support families, right? And so those are phrases that I use when I have some conflicts with my healthcare team. And a lot of times I am being like, hey, let's get somebody else's opinion on this. So I'm going to pause here. I want to hear some questions. I want to hear like what you guys are thinking.
I do have one question on the queue. It says, why is it that gabapentin is prescribed more for AUD than acamprosate?
I think there's a little bit more evidence than acamprosate. Both of them you have to take 3 times a day. Sometimes renal changes, like if the kidney is doing one thing, somebody will favor one over the other. Gabapentin also can prevent some of the problems with withdrawal from alcohol, some of the seizures or the trembling or the anxiety a little bit more than acamprosate can. So that might be the other reason. But both of them can be used.
As long as their patient's getting something, right? And if they need it, definitely. So, any other questions for our doc? This is your chance. Don't pass it up. We'll wait a second. And I love one thing, there's a comment here about good to know about the long-term outcomes. It is stigma. I've met patients that are struggling with substance use and mentioned that how they were exposed to substances during birth. You know what? I've experienced that too. So yes, I think it's the stigmatizing and the myths that we knew. So you are an expert now to know that, anybody can change their lives. So love that, Dr. Rebecca Trotzky. That was just amazing. Okay, go ahead. I don't, we got one more. Is there a worse way to take drugs injection over smoking?
Yeah, this kind of gets into the universal wellness services. So of course we want everybody to make really healthy choices. And sometimes those choices are, how do I make a safer choice around drug use? So injection is more risky than smoking. Smoking is more risky than somehow orally consuming it, right? So those are all because of the contaminants that can get into drugs. We don't want them getting into the blood and the brain and causing infections. We don't want them to get into the lungs. So your gut system tends to filter out a lot of things. I mean, obviously there's differences for some drugs, but we want to share these universal wellness messages, both for people who are pregnant, parenting, and everybody, right? Like we want to make sure that you have a buddy with you, try not mixing drugs, like have clean access to syringes. All those things are important. I have my little one entering my room, but so these are the same messages that you have heard about harm reduction and universal wellness for people using drugs. They also apply for pregnancy. And sometimes it can feel really hard to say to somebody who's like 8 months pregnant, hey, I know you're going to be using drugs. Here's how to do it more safely, because your brain might be saying, I wish you wasn't going to be using drugs. And that's okay. And your job is to hold that in mind. Like, hey, hon, I wish, and I know I have this wish for you, and I know you have this wish for yourself and and also let's talk about how to do this more safely. That's okay to say. Um, what are the
Are you
we
still
have?
there? Okay, we lost you for a second. Are you there?
Yeah, I'm here. Just the same, these are all the same slides that we do all the time. It's important to just keep in mind most of the things are exactly the same for pregnant people and non-pregnant people. I'm gonna stick around for questions. My kids in the background slamming doors, so love you guys. What else can I answer for you?
I think we'll give Kara wants to know where fentanyl strips. We'll give you the California Department. Yeah, try to just put that in the chat. I think the only other question is there a higher rate of gestational diabetes with OUD, SUD, AUD, and pregnancies?
Not heard that. Most of the drugs will end up with smaller sized babies. When you have diabetes, often you have a bigger sized baby. I say this only because it is true, diabetes also exists in our communities, and you will have diabetes and also have substance use disorders. And it's particularly can be a challenge when somebody needs to be on insulin, to remember to take the insulin. And during pregnancy, it's really important to control diabetes. And so using drugs with diabetes while you're pregnant, that can be really hard. So Tanya asks, will you go over methadone for pregnant patients? So the methadone centers are going to be most of the people managing methadone while somebody is pregnant. There should not be a significant dosing start change while somebody is pregnant. They don't necessarily have to be monitored while they're starting buprenorphine or methadone in terms of like going to somewhere and having, the pregnancy and baby with an ultrasound. But sometimes you do need to go up on your dose for both methadone and buprenorphine while somebody is, maybe double their usual size. And sometimes you need to split it because you're, metabolizing so quickly. I'm seeing, Tanya is saying we're seeing methadone at our hospital for pregnant patients. That's an awesome option. And also I wonder if, some of my doctors who are not as familiar with buprenorphine will start methadone, because that's something that's been going on for so long, the use of methadone to treat opioid use disorder. So I would want to make sure that doctors are aware of buprenorphine, and then also, feel comfortable starting methadone too. So Tanya, maybe this is an opportunity to have a really focused discussion with your clinicians at your hospital. But thank you guys so much for this.
Yeah, thank you. I was just going to say we have 2 more minutes. We have a few more slides. If we didn't get to your question, we will follow up. Make sure that we will. We will not leave you hanging, I promise. So me or my team will get back to you. And now we have Elizabeth. Are you here? I know you had to jump off. Are you back?
I'm back.
Okay.
I unfortunately just had to put Rebecca on mute, which is a tragedy because I learn every time I talk to Rebecca. Thank you all so much for taking the time to learn about this topic today. I wanted to make sure everyone knows that the Bridge program has been actively expanding for about a year and a half now, and we have a program that is focused on not substance use disorder, but pregnancy emergencies and treating patients' reproductive health needs from the emergency room. So if you do find yourself working with patients who might be struggling with things like access to contraception, or who might want emergency contraception nearby, or if you are ever working with a patient who has suffered an early pregnancy loss, which we call a miscarriage, and is maybe dealing with the effects of the early pregnancy loss along with their substance use disorder, we have a lot of information for physicians who are treating those patients. We do know that similar to substance use disorder, there is so much more that EDs can be doing to support patients who are pregnant and seeking help, or trying to make their own choices about their reproductive health. So just to know that Access Bridge exists, keep us in your back pocket. And if you ever do find yourself needing to help a provider who's treating a patient with a pregnancy emergency or other repro needs, just go to our website and we can help you out. You can also always reach out to your fabulous Navigator team, Sherry, Latoya, and Chaya, and they'll help you figure out if the Access Bridge resources are right for you. So I hope everyone has a great rest of your day. Bye, guys.
Bye. Thank you, everyone. And you will receive a follow-up email with the evaluation. You fill that out and you'll get your CEU. We thank you. And as usual, if you if you need any assistance or have any questions, please contact us at mentors@cabridge.org. I am Sherry Cisneros, and always reach out to us. I want to thank Dr. Rebecca Trotzky-Sirr. You know, we never have enough time. I'm sure there will be another opportunity to bring you back, because I saw lots more questions, and we will follow up with that later today, either by email or on Slack or somehow to get that information. Thank you, everybody. And until next time, bye.